Hello and welcome to a special episode of Hema Now, EMJ's dedicated hematology podcast. Since its launch in September 2024, Hema Now has brought you some truly remarkable guests and explored the latest breakthroughs in hematology. With our 12th episode now live, we thought it would be the perfect time to reflect on the insightful conversations, key topics, and expert perspectives we shared so far as a way to tempt you to subscribe so you become an engaged member of our online community. The series opened with Sunil Gupta, consultant hematologist and hemato-oncologist based at Lewisham and Greenwich National Health Service Trust here in the United Kingdom. As an accredited yoga teacher, he spoke on the health benefits, both physically and mentally, from practicing yoga. So here he is now.
That yoga is not only restricted to meditation and mindfulness and yogasana, and also about the breathing. So it has got 8 wings or 8 arms, so to say, and that also includes how to become a better human being. So it actually also builds up your character. So if you put a child early on into the yoga curriculum, it also helps them becoming a better human being. You inculcate good qualities. Things like not to lie, not to harm anybody, not to grab money, not to be greedy, and then of course then comes the breathing part of it, and then the stretching part of it. So that's your mental well-being and physical well-being. Now, if I'm actually trying to translate the science of yoga into medicine, it is pretty easy, I would say. Look around, what's happening in the NHS, where the entire money is going. The money is going into mental health, the money is going into diabetes, the money is going into hypertension, the cardiovascular problems. And all these things are prevented or can be prevented easily if you actually put the children or put the habit of doing yoga or any physical activity for that matter early on. And that actually will have a far-reaching benefit on the NHS budget, because prevention shouldn't be forgotten.
We also chatted to Antonio Almeida, 2024 president of the European Hematology Association. He discussed their recent congress, reflecting on his most proud initiatives and accomplishments. We also talked about the importance of public policy in shaping hematology and the potential of AI in the field. So let's take a look at what Antonio had to say.
And one of the areas we look at is exactly what you're describing, is AI for diagnostics. So imaging is a very clear application, but we're using that for morphology as well. So we're starting to use AI to look at bone marrow smears, bone marrow trophines, lymph node biopsies. And as we load more and more data, then it's able to recognize patterns and accelerate diagnostics. And even in many ways, reduce the need for additional stains and for additional tests that may be needed. The other big area is with all the information now that we have on genomics, especially with next generation sequencing, and we do whole genome sequencing, etc., is using AI to analyze this and to identify different mutational, or even if they're not mutational, different polymorphisms and patterns of polymorphisms that will identify populations of patients that benefit from differential treatments. And I think that would be very powerful. And finally, as I've mentioned before, we're definitely investing in AI for registry analysis and for improving data for drug approval and accelerating drug approval. So as I say, it's a very exciting, brave new world that's coming up.
Joshua Zeidner, Associate Professor of Medicine at the University of North Carolina, discussed treatment outcomes in IDH1 and IDH2 mutated acute myeloid leukemia, AML, and the safety and efficacy of new agents in AML. He also shared his thoughts on treatments for patients with AML with a TP53 mutation and the time from research lab to bedside in AML and myelodysplastic syndrome. So let's take a look at Joshua's thoughts on the reliance on transfusion in myelodysplastic syndrome.
Yeah, I think so. A lot of our endpoints in any cancer, but in particular MDS, acute myeloid leukemia, are really mostly based on survival. There's lots of surrogates of survival, disease-free survival, event-free survival, complete remission duration. And then, of course, we have the activity of a specific agent or combination, which is looking at complete remission and other sort of markers of activity. But, in MDS in particular, this is a disease of the elderly. The median age of MDS in the United States, at least, is about 70 years old. Most of these patients are older, have lots of comorbidities, and unfortunately are not on this potential curative path, where with all these hematologic malignancies, there is a potential cure with an allogeneic bone marrow transplant, allogeneic stem cell transplant in patients who achieve a response or remission with therapies that can be potentially curative as a treatment, but it is not possible for an older or a frailer patient population. And that's unfortunately the majority of our MDS patients. These patients are largely at diagnosis. Many of these patients are dependent on transfusions, blood transfusions, sometimes platelet transfusions. And if you ask a patient how they feel, it's very dependent on how their blood counts are doing and how frequently they need to come back and forth to the hospital and their reliance on transfusions. If a treatment works, you would expect their transfusions to improve and their quality of life to improve, but that may not always be the case with some of our treatments that can also exacerbate their blood counts. And sometimes treatments can really benefit their blood counts, but we don't see it in like in the survival and other measurements. So that's the main issue with kind of coming up with the patient centric sort of analysis that can really tell us like how does a patient feel day to day, how can we improve quality of life and other markers that can maybe even be compared on a randomized study and can help lead to maybe more regulatory approval. So we came up with this kind of clever approach called the Twitter analysis, which is basically time dependent on transfusion independence and being in without relapse of their disease, their MDS. So this was kind of a analysis that we did that basically allowed us to understand how long a patient is transfusion independent or without reliance on transfusions and without active disease. And we applied this to a randomized phase 2 study, azacitidine and pevonedistat versus azacitidine alone, and we validated this kind of surrogate within that analysis. I think it's interesting that we can use a lot of these kind of surrogates of quality of life in order to really understand the benefit that these treatments are having on patients beyond just survival or activity.
Next up, we had Christopher Patriquin, Assistant Professor in the Division of Medical Oncology and Hematology at the University of Toronto in Canada. He shared some fascinating insights on diagnosing and treating rare diseases and the challenges faced by thrombotic thrombocytopenia purpura survivors, especially in relation to cognitive decline. Christopher also highlighted developments in complement component type 3 cells in paroxysmal nocturnal hemoglobinuria and discussed equity in access to care. So let's revisit his take on the importance of apheresis medicine.
Absolutely, it's where I spend most of my clinical time, and so broadly, apheresis is a category of a medical procedure in which a blood component, a plasma or cellular, can be removed and possibly replaced depending on what you're looking to do and what you're hoping to treat. The most common therapeutic apheresis modality is plasma exchange, and that's where a patient's plasma is removed whilst we simultaneously replace it with usually albumin, but plasma when there is also perhaps a component missing in the patient's plasma. So it's very highly effective in treating really antibody-mediated diseases, particularly in acute situations where there may not be enough time to wait for immune suppression to just reduce immunoglobulin production, where physical removal is needed. And this is particularly the case where those plasma components have a longer half-life, like IgG-based autoantibodies. The prototypic hematologic disease for this really is acquired TTP, and in that situation, we replace the removed patient plasma with donor plasma because the procedure serves both to remove anti-Adams TS13 antibodies that are causing the disease, and also replace the deficient protease, the Adams TS13 itself. But this is really just one of the many indications for plasma exchange in hematology and beyond. And of course, we can use it hematologically for other things like red cell exchange for patients with sickle cell disease. And that allows us to rapidly reduce their percentage hemoglobin S to reduce sickling and its many complications. But it's a very broad and fascinating field, and really uh, is important to have multidisciplinary collaborations here, because you can't be an expert in every disease that you might treat with that machine. We try our best to learn as much as we can for what we're treating, but if it's a neurologic condition, if it's a endocrine disorder, then we certainly have to collaborate broadly.
David Almaguer Gomez, head of the hematology service at University Hospital Monterrey in Mexico, joined us to talk about stem cell transplantation and therapies, including CAR T cells and new treatments for diseases like aplastic anemia and chronic lymphocytic leukemia. David shared his thoughts on the current status of cord blood donation and the impact of race and ethnicity on outcomes after transplantation. Here's a look back at his thoughts on the effect of resource and budget constraints on healthcare quality.
Well, we have a very creative group of people, all several, more than 10 people in research here. And I used to say we have to provide the best therapy available, but the less costly at the same time. So we have used these ideas all the time in order to provide therapy and not to increase the cost. For example, our transplant unit is devoted to created like outpatient unit. So we perform all autologous transplantation out of the hospital at 90%. Allogeneic identical 50% are never spend a night in the hospital. And haploidentical is more complex situation, but still 20%, 25 never sleep in the hospital. Therefore, the cost is low, and the use of hospital that is costly is reduced. The haploidentical, this is more complex, but still they spend a median of 10 days in the hospital only, not the usually 30 to 40 in a normal unit. That's the one way we have done things. And the other is that we have take advantage of the low dose of many drugs that you don't need to use in the maximal dose, because maximal dose is the higher doses are not really that what the patient needs. And the combination of some cheap drugs like itraconazole, for example, with venetoclax, increase the dose of venetoclax and the effectivity. We don't lose effectivity. And we have published several papers using low dose of several drugs. And we have published how to use and how not to lose effectivity. And of course, the cost is half or less than half. The other, recently, we published a paper, very recently, a month ago, a few days ago, that we don't need to the irradiate the blood, because several years ago, more than 20, the idea that you have to irradiate the blood in order to avoid complications was important. But we stopped that, and we changed to filters. And we published the second paper in the field showing that we don't need to irradiate blood. In fact, the guidelines of the British Society of Hematology mention one of our papers suggesting that we don't have to do that. And they published also a paper uh, where almost 1,000 patients were transfused by mistake with blood without irradiation in England, and they showed that there were not really any complication. So this is we avoid to get that expensive machine, and also we avoid the cost of irradiate the blood. So in in summary, I have to say that we have any many ideas how to treat patients without high cost. But or as I said, we are looking for the best therapy to less costly and less costly. Is that possible?
Our next guest, Shahram Kordasti, Associate Professor in Applied Cancer Immunopathology at King's College here in London, England, discussed the immunobiology of diseases like Hodgkin's lymphoma and myeloproliferative neoplasms. He also explored the use of computational biology and multiomics for patient stratification. So let's hear more about some of his research.
Yeah. Uh, okay. It's very interesting. When I finished my training as a hematologist, I thought I want to just go to clinic, become a consultant hematologist, and end of story. But somebody told me that, well, if you want to be a very good consultant, you have to uh, have some research background, and that's important. So I decided to, okay, let's do some research. And my understanding of research was what we used to do as an audit or something, very clinical. Again, I went and started doing an audit, and then somebody told me, "Have you heard?" And on that time, my clinical interest was myelodysplastic syndrome and bone marrow failures. And say, have you heard? There is a paper published about T cells become clonal in MDS, and there are a few papers suggesting that that might be a role for T cells in MDS. And my reaction was, MDS is a myeloid disease. Why T cells are even important? But then I became curious, and I look at a few papers and I say, oh, yes, there are papers suggesting that we can give them immunosuppressive therapy, which is, again, for me, was very interesting that in a malignancy like MDS, you give immunosuppression. And so I decided to do a bit of research on that. So I started reading a bit more and do a bit of lab work, but nobody worked on it. So nobody knew about this. And they were repeating the same thing. Well, it's a myeloid disease. So anyway, I went to States, to Cleveland Clinic with Dr. Masiejewski, who you may know is a very well-known person in the field. And on that time, I decided to do a PhD. Part of my PhD, I went to his lab, and I remember the day I arrived, he asked me, "You're interested in clonality of T cells, but that's not uh, something useful, and I think you should think about something else." And then he said, "What if you look at Tregs, regulatory T cells that called Tregs?" And I never heard of Tregs, and what I heard was Tregs, and I thought, and I was very shy to ask again. I said, okay, there should be something related to Tregs that now it's related to cancer. I'm sure there is something. I left his office and I spent maybe 2 days or 3 days, and I was searching Tregs and cancer. And all was coming up in my search was, these cartoons and, funny things about T-Rex, nothing to do with science. Anyway, long story short, I went back to him and he was laughing like mad at what are you talking about? And so since then, I became interested in these regulatory T cells, which was I completely misheard and I thought it's something else. And then I published the first paper when we were working there, and I became more and more interested. And I realized how important it is and how relevant the concept of immunosuppression and activation of immune system in early malignancy and also in myelodysplastic syndrome and other myeloid diseases.
Mark Hoffman, Associate Professor in Hematologic Malignancies and Cellular Therapeutics at the University of Kansas Medical Center, then joined us to delve into molecular biophysics and the latest treatment advances in diffuse large B-cell lymphoma. Mark shared insights from the Bruin study and challenges implementing CAR T therapy. So let's take a closer look at his thoughts on the regulatory aspects of clinical trials.
Yeah, so that's it's something called a DWG, and what we do is that we're responsible, and this is true of all centers that perform clinical research. We're responsible for choosing a portfolio of clinical trials that we think we can enroll on, right? So that's always a question: do we have the patient population where we feel like we can put patients on the study? And then the second piece is that study a relevant study? Is it going to advance the science of the disease? Is it going to make a difference to patients? If we have the results of that study, if we knew those results today, would we be treating patients differently? And so we have, as all situations are, we have limited resources. I don't have as many clinical research coordinators as I want. I only have so much clinic space. There's only so many regulatory people. And so we have debates in that context in our monthly meetings, sometimes which can be quite robust, about which trials we should open and why we should open them. And so that's the forum in which that takes place. I'm also on something called a protocol review and monitoring committee, which does a couple of different oversight functions. One of which is we review all of the new protocols and determine whether those are protocols and ask mainly enrollment questions. Can we enroll? But also ask some really critical questions about whether the study questions that are in there are valid. And then we monitor every year each of these trials to make sure that they're meeting accrual goals and meeting scientific goals. And that group actually has the power to stop trials. So we can actually discontinue and remove a trial from our portfolio. And so it's nice to be on both of those, where I'm on the activating side and the deactivating side. The deactivating side is really helpful when we're trying to pick studies, and I'm saying, well, this study is not going to go anywhere. But that I think it's probably one of the more interesting jobs that I do, because I learned so much about how my colleagues think about these diseases, and we get to go through so many different protocols and really understand how is the protocol written? Is that going to make this problematic to enroll on? And sometimes we're able to actually provide feedback to companies, and they adjust their protocols in relationship to the feedback we've provided to be able to make it a better study. So that's the work that we do through that committee.
Following Mark Hoffman, we had Anna Sereda, European Society for Blood and Marrow Transplantation president, who spoke about memorable travels and her journey into hematology. She also highlighted breakthrough treatments in lymphoma and stem cell transplantation. So let's hear some of the exciting EBMT initiatives.
Exactly. So, as you have said, EBMT is the European Society for Blood and Marrow Transplantation, and nowadays we are including, let's say, in the landscape, new cellular therapy strategies, for instance, CAR T cells that I have already mentioned, also gene therapy, which is a rising star in the field, and it's going to be more and more used to treat some eventually non-malignant hematological disorders. So I became the president of the society. That was back in 2022, and I had been working for EBMT many years in different positions. So I have to say that I think I know a little bit the society. So after COVID, which was of course a big challenge for all of us in different aspects, the 2024 meeting happened in Glasgow. It was the second face-to-face meeting or hybrid meeting after COVID pandemic. So in 2023, it was in Paris, 2024, it was in Glasgow, and it was a very special meeting for EBMT because we celebrated our 50th anniversary. So EBMT was created in 1974 by three clinical scientists that were very much interested in in dealing with stem cell transplantation, in sharing information and experiences with stem cell transplant. And of course, nowadays, it's a big society that is basically looking at Europe with more than 600 member centers. But of course, we have also quite a few centers in other areas around the globe. As I have said, Glasgow was in a special meeting because it was the 50th anniversary. So we had quite a lot of parallel celebrations and several specific sessions that were looking at the advances of stem cell transplantation and cellular therapy in general, that were reminding basically everybody, but the young ones attending the meeting, um, so how EBMT was born, and how EBMT had been developing. So we try to make the Congress as inclusive as possible. And EBMT is working over the last few years in the EDI concept. Equality, diversity, and identity. So we try to welcome everybody. And in this sense, of course, I have to say that, of course, not only physicians are coming to this meeting, but this comes from many, many years ago. This meeting is open to all healthcare, or to all professionals that are related to the healthcare in relation to stem cell transplantation, not only clinicians, but also translational and basic scientists are very much invited. And one of the efforts that EBMT as a society is doing right now is to try to increase a little bit more the reach when we talk about translational and basic science, because EBMT is basically a clinical society. So that would be one of the pathways that we have just started and we are following. We are also very conscious also about our young colleagues, and we try to find the best of the best substitutes or followers when the older ones, including myself, leave the society and leave the profession. So several years ago, we developed the trainee committee, trying to bring as much as possible all trainees coming from around the world. We are especially proud of our registry, which is the only European registry looking at the stem cell transplantation and CAR T cell treated patients. We upgraded our registry that was in August 2023 to a new platform, which is modern, which is more friendly user friendly. I have to say that I never know which is the exact wording. Uh, for user friendly. I hope I don't forget it. So anyway, user friendly for all our users. In principle, full members of EBMD are requested to report all consecutive transplants to the registry, and the registry has more than 800,000 transplants nowadays, and more than 10,000 patients being treated with CAR T. The CAR T cell registry started in 2019. Of course, it's not a 100%, let's say, comprehensive registry, because we acknowledge that not all the patients basically being treated with CAR T are reported to the EBMT, but we are getting there. So this is one of our major assets, and a very differential thing that differentiates EBMT from other scientific societies. In terms of the educational program, as I have said, we try to be as much inclusive as possible, and we have different tracks that are looking at the different types of professionals that are attending the meeting. We are looking at results of stem cell transplantation, how to improve the outcome in terms um, of treatment of complications. We try to bring stem cell transplant in the era of new drugs. And this is very important because, as we have mentioned before, there are many new drugs, not only in lymphomas, but in the rest of the diseases. And stem cell transplant is a kind of moving target, depending on the results of new drugs, and of course our capacity to combine stem cell transplantation with new drugs, with the objective to optimize the results of stem cell transplantation itself. And of course, we are looking at more newer cellular therapy strategies, gene therapy, CAR T cells that had a very prominent position in the educational scientific program for Glasgow. And of course, in this sense, we try to be as open as possible. And as cellular therapy is being looked at not only by hematologists, but maybe by other specialists, now that we have CAR Ts being tested in autoimmune disease, we also try to bring all these professionals into our landscape, our arena, to make the society as broad as possible.
We also heard from Frederick Scheswald, a leader in myeloma research at Oslo University Hospital. Frederick discussed the latest innovations in myeloma therapies, CAR T cell therapies, and biospecific antibodies. It was a great conversation, so let's take a look back at Frederick's take on the latest breakthroughs in amyloidosis.
It's sort of just a consequence of a myeloma disease, or a benign or malignant myeloma disease. So what happens is that myeloma cells, even if they're not sort of cancerous, just a pre-stage, they secrete what we call light chains, which are small protein fragments of antibodies. And for some reason, chemically or physically or whatever you call it, this is not being known really well. These can, if they are usually not, they are a bit destroyed. They are not as they're supposed to be, these fragments, and they don't sort of form the shape they're supposed to do. They can start to become fibrils, attach themselves with some other proteins and make fibrils in different organs. And some patients get this in the heart or in the kidney or both. This is the most common, but you can get it everywhere. You can get it in the skin, in the GI. You can get it in every possible organ in the body, except in the head, because it doesn't penetrate the blood-brain barrier. And this can be accompanied with a full-blown myeloma, or it can just be a pre-stage myeloma that has this in addition. So it's a small disease compared to myeloma, so it's not been many randomized trials. So we mostly use treatment that are approved for myeloma instead. But some years ago, and updated now in December with survival results, is the first randomized trial showing a benefit of a new drug. And that has been showed further. It has been approved in US and Europe. This is daratumumab, again the CD38 antibody, in addition to chemo and bortezomib and dexamethasone. Previously, it was approved based on renal and heart response, that their heart and or renal function got better. And the hematological responses were better. You saw the sort of clone go down. But now, finally, last week, the overall survival was presented. So it's actually increasing survival as expected. People usually die from their heart disease. And if that gets better, it's quite logical that you will get an overall survival benefit. But now it's proved. So that's the only approved treatment, because it's the only randomized trial that has shown benefit, and not many randomized trials have been performed at all. But there are studies now using these immunotherapies, bispecific antibodies, and CAR T cells to this disease. And those results aren't very mature yet, and they are phase 2 trials, just non-randomizing trials. But we have always, I think the treatment I just discussed, DARA VCD as we call it, in frontline will be the standard. But these other phase 2 trials will lay the ground for using these immunotherapies in second line when reimbursed for myeloma there, because we can just call this myeloma. But it's a strange disease. If you have heart disease, your prognosis is much worse than myeloma. If you have amyloidosis without heart disease, and without myeloma, your prognosis is better. So you have best is amyloidosis without heart, then it's myeloma. But the worst prognosis is if you have a heart disease by amyloidosis. Then the problem is that the heart function, not invariably but close, gets worse when you treat it, and many patients decompensate when you start treatment. So, but you don't have an option. You can either risk and treat, or you can risk and not treat, and they will die anyway from the disease. So you just have to try. So it's a difficult disease, especially the heart disease, and it's a bit it's we see it, of course, regularly, but it's a much rarer disease than myeloma.
Finally, we had Eitan Stein, chief of the leukemia service at Memorial Sloan Kettering Cancer Center in New York, who highlighted the current landscape of treatments for leukemia. Eitan shared insights into epigenetics, targeted therapies, and the BEAT AML clinical trials. So let's take a look at his thoughts on reducing patient fear through education.
So I think the benefit is number one, it's always better for patients to understand their disease. I find that in my practice, the first time you meet that patient and you tell them they have, in my case, acute myeloid leukemia, I think that everything I say after I say the words, I believe you have acute myeloid leukemia, is lost. They hear cancer and then they're sort of, they tune out because of their, because they're legitimately so worried about what I've said. So patient education is important because it gives the patient the opportunity to listen unfettered for, half an hour to an hour to someone explaining their disease to them in a way that they might not get in their clinician's office. So I think that's number one. I think number two, patient education is important because it informs patients about advances in the field that they might not know about, and clinical trials that might be available to them or for them that they might not know about, and sometimes their doctors don't know about it. I'm highly specialized in my field. I know a lot about acute myeloid leukemia and MDS, but you wouldn't want to ask me about lung cancer or prostate cancer or bladder cancer. And there are some doctors who sort of do, and I have the utmost respect for them because it's something I couldn't do. They have a breadth that is much bigger than mine, but they might not have the depth to know all of the clinical trials. So hearing about from experts in the field who really have the depth to communicate the trials that are available and the advances in the field, the patient can then take that back to their local physician and ask their local physician about it.
I have to say, overall, what a series it's been so far. I'm honoured to have spoken with such a diverse array of guests from countries around the world. Make sure to check out the full episodes on our website and stay tuned for our Hematology Journal, publishing on the 24th of July 2025. Until next time, I'm your host, Dr. Jonathan Sackier. Please join me on Hema Now the next time, and until then, please stay safe, stay well, stay curious. Bye for now.